Good afternoon. My name is Nita Joseph, and I am presenting today on behalf of the Integrated Care Resource Center, or ICRC. Thank you all for joining this webinar on D-SNP-Only contracts, benefits, and key steps for states. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines have been muted as you joined the webinar today. We are recording, so you can revisit today's presentation or share the recording with colleagues who were unable to join. We will send you the link to this recording and the slide deck later this week. We will also have a Q&A segment at the end of today's webinar. To create a space where you feel safe enough to ask questions, we will stop the recording during that Q&A session. You will be able to submit questions at any point during the webinar via Zoom using the Q&A icon at the bottom of your screen, or by unmuting your phone lines using the microphone icon on the bottom of your screen as well. If you'd like to use the closed captioning feature, you can click on the More option in the Zoom toolbar at the bottom of your screen and select the Captions option. You are also able to edit the caption settings to adjust the text size by going over the subtitle setting option. As you leave today's webinar, a short evaluation survey will pop up on your screen, and we'd greatly appreciate it if you would just take a minute to share your feedback. During our presentation, we'll start with a refresher on exclusively aligned enrollment, or EAE, which is a core requirement for implementing D-SNP-only contracts. Then we'll provide an overview of the D-SNP-only contracting flexibility codified as Section 422.107E of Title 42 of the Code of Federal Regulations, which we will refer to as 107E throughout this presentation. After that overview, we'll go over the benefits for states, D-SNPs, and D-SNP enrollees of this new flexibility. Finally, we'll finish off with some key steps for plans and states in implementing D-SNP-only contracts. Presenting with me today are my ICRC colleagues, Haley Gallo-Sutherland and Diane Beaver. Molly Knowles will facilitate the Q&A portion of the call. We are also joined on the line by other ICRC colleagues, as well as our colleagues at the Medicare and Medicaid Coordination Office at CMS to help answer any questions during the Q&A portion of the call. As I mentioned earlier, in this first section, we'll provide a refresher on exclusively aligned enrollment. Let's start by defining what aligned enrollment is. Aligned enrollment occurs when a duly eligible individual enrolls in a D-SNP and an affiliated Medicaid managed care plan offered through the same parent company in the same geographic area. These two diagrams help to show the differences between aligned and unaligned enrollment. The diagram on the left shows a scenario where not all D-SNPs have an affiliated Medicaid managed care plan through the same parent company. Also in this scenario, duly eligible individuals can enroll in D-SNPs and Medicaid managed care plans operated by different parent organizations. This scenario will result in a mix of aligned and unaligned enrollment. For example, someone might enroll in both Company A's D-SNP and Company A's Medicaid managed care plan, and they will have aligned enrollment. However, someone else might enroll in Company A's D-SNP and Company B's Medicaid managed care plan, and they would have unaligned enrollment. Additionally, in the diagram on the left, Company C operates a D-SNP without an affiliated Medicaid managed care plan, and therefore none of Company C's D-SNPs can have aligned enrollment. In contrast, the diagram on the right shows a scenario where all D-SNPs have an affiliated Medicaid managed care plan, and all duly eligible D-SNP enrollees must enroll in a Medicaid managed care plan affiliated with their D-SNP. In this scenario, all individuals have aligned enrollment. As the diagrams on the slide illustrate, the plan options in the diagram on the right side can be simpler for D-SNP enrollees to navigate and for states to explain to potential D-SNP enrollees. When a state's D-SNP contract limits enrollment in their D-SNP to full benefit duly eligible individuals who receive their Medicaid benefits from the D-SNP or from an affiliated Medicaid managed care plan offered by the same parent company as the D-SNP, this is called exclusively aligned enrollment. Exclusively aligned enrollment allows the use of several strategies to integrate coverage of Medicare and Medicaid benefits for dually eligible enrollees, including fully integrated enrollee materials, single ID cards, and unified appealing grievance processes. EAE creates an environment that can be used to promote enhanced enrollee and provider experiences. The graphics on this slide represent specific health plan features that states can enable through the use of EAE. It's important to keep in mind, though, that these features do not occur automatically when a state implements EAE. In most cases, states need to require these features within their state Medicaid agency contracts and/or work with their D-SNP to implement each of these features. I won't read every single benefit that's listed on this slide, as the benefits of EAE is not the focus of today's presentation, but just to name a couple of examples, as the orange flower on the bottom of the slide mentions, EAE allows D-SNPs to provide a single set of Medicare and Medicaid informational materials to enrollees, which prevents enrollees from having to separately navigate information about Medicare and Medicaid benefits. As the bright green flower in the corner states, when D-SNPs operate with EAE, they can also offer enrollees a single plan ID card for both Medicare and Medicaid benefits, as well as a unified integrated customer service line, even if the benefits are ultimately being provided by two separate but affiliated plans. The light blue flower notes that EAE also supports consolidated Medicaid and Medicare billing for providers, so their experience of working with the plan can feel integrated as well, and they can submit a single bill for services rendered while receiving coverage and payment from both Medicare and Medicaid sources. There has been a steady increase in the number of dually eligible individuals with EAE and D-SNPs over the last few years. In this bar chart, we compare the number of people with EAE by state in 2017 on the left side versus in 2023 on the right side. In 2017, 7 states, including California, Idaho, Massachusetts, Minnesota, New Jersey, New York, and Wisconsin, had exclusively aligned enrollment. And by 2023, the number of people with exclusively aligned enrollment had grown in all of these states, with Idaho, New Jersey, and New York essentially tripling their number of enrollees. We also have the District of Columbia, Florida, Tennessee, and Virginia with exclusively aligned enrollment in 2023 that did not have it in 2017. We're going to expect that more states will move to using exclusively aligned enrollment in the next few years, particularly as states with financial alignment initiative demonstrations transition those to the D-SNP based models. Now, as many of you are aware, a final rule issued by CMS in May of 2022 gave states the flexibility to require D-SNPs with exclusively aligned enrollment to operate under what is now being called D-SNP-Only contracts. Codified at 107E, there is now a way for states can require D-SNPs with that operate with exclusively aligned enrollment to have D-SNP-only contracts with CMS. This means that states can require D-SNP's contract with CMS to only include one or more D-SNPs within a state and not other types of Medicare Advantage plans. Within this new authority, states have the flexibility to require that all of a parent company's D-SNPs operate within the D-SNP-only contract, not just the D-SNPs operating with exclusively aligned enrollment. So for example, if a parent company has one D-SNP operating with exclusively aligned enrollment and another that is not, the state can require the parent company to include both of those D-SNPs within the parent company's D-SNP-only contract with CMS. It's also important to note that when D-SNPs operate within D-SNP-only contracts, they must integrate certain materials and notices for D-SNP enrollees. Integrated materials are materials that combine Medicare and Medicaid information in a more streamlined way that is designed to make it easier for D-SNP enrollees to understand and navigate their full array of benefits and rights within the integrated plan. rather than presenting Medicare and Medicaid information separately. Some states have started to use this flexibility in their 2024 contracts. Okay, so with that background in place, I'm going to now pass it over to my colleague Haley to explain the benefits of D-SNP-only contracting.
Thank you, Nita. We're going to switch gears now to talk about how D-SNP-only contracting can benefit states, D-SNP enrollees, and D-SNPs. So can you go to the next slide, please? Let's first take a moment to level set about Medicare Advantage plan contracts, because this will help us to clarify what a D-SNP-only contract is. One sponsoring organization or parent company can hold multiple contracts with multiple plans. And these contracts can contain D-SNPs and non-D-SNP Medicare Advantage plans. And the contracts can also contain plan benefit packages or PBPs that operate in multiple states. So the image on the right side of the screen shows an example of this. The parent organization holds two contracts. Contract H1234 has two different plans. One non-D-SNP Medicare Advantage plan that operates in Arkansas, and a D-SNP plan that operates in Missouri. The parent organization also holds contract H9999, which operates a regular Medicare Advantage plan and a chronic condition special needs plan in Missouri, as well as a D-SNP in South Carolina. Much of the information about the way a D-SNP operates and performs is available only at the contract level, not at the individual plan benefit package level. So this limits states' ability to use these resources to oversee individual D-SNPs within their state. So in the example from the image on the right, South Carolina might be able to only review quality measures, models of care, and other Medicare Advantage resources for all of the PBPs that are combined under contract H9999, rather than just for the D-SNP that operates in the state. But in contrast, having D-SNP-only contracts would mean that the only plan benefit packages allowed in the contract would be D-SNPs that have exclusively aligned enrollment with Medicaid managed care plans in a specific state. Next slide, please. There are several ways that states can benefit from requiring D-SNP-only contracts. For example, having D-SNP-only contracts can allow states to review quality measures and Medicare Advantage star ratings that are specific to each D-SNP. It allows states to access HPMS, or the Health Plan Management System, so they can monitor the D-SNPs. It enables customized D-SNP models of care, and it creates more transparency around D-SNP healthcare spending. And the next few slides go into additional detail about each of these benefits. So next slide, please. First, D-SNP-only contracting can allow states to review D-SNP-specific quality measures and Medicare Advantage star ratings. Many quality measures and Medicare Advantage star ratings are calculated at the contract level. And as I mentioned earlier, contracts can include both D-SNPs and regular Medicare Advantage plans, and plans that operate across multiple states. So this means it can be difficult for states to understand the quality measures and star ratings that are specific to the D-SNPs operating in that state. But D-SNP-only contracting enables reporting of quality measures and calculation of star ratings that are specific to D-SNPs within one state. So as a result, states with D-SNP-only contracts can use the Medicare star ratings to better understand how D-SNPs are doing in your state on a variety of quality and performance measures, like looking at enrollees' experiences with care or receipt of important healthcare services like follow-up care for mental illness or hospital readmissions. Next slide, please. D-SNP-only contracting also improves coordination between the state and CMS on monitoring and oversight of D-SNPs. And that includes granting states access to HPMS for oversight and information sharing related to the D-SNP-only contracts. HPMS is the system of record that CMS uses to facilitate data collection and reporting activities with Medicare Advantage and Part D programs. State access to HPMS can enable states to more readily review D-SNP materials and activities. And HPMS can also facilitate joint state and CMS review of materials that are submitted in HPMS, like the integrated enrollee communication materials and models of care. Next slide. And just like with Medicare Advantage quality measures, models of care are also written at the contract level. All D-SNPs must develop a model of care that is a separate document from the state Medicaid agency contract. And the model of care, plans use it to describe the D-SNP's processes for coordinating care for dually eligible enrollees. And because D-SNP-only contracts are state-specific, this means that everything in the model of care is applicable to the D-SNPs in that state. With D-SNP-only contracts, D-SNP's models of care can better reflect the state's care coordination goals and specific details about the state's Medicaid program and D-SNP eligible populations. Working with D-SNPs to have state-specific models of care can promote better coordination of Medicare and Medicaid services for D-SNP enrollees. For example, states can require D-SNPs to describe in their model of care how the D-SNP will incorporate information about the state's Medicaid program into required trainings for D-SNP care coordinators. And the state can even specify that the model of care needs to note that D-SNP care coordinators must participate in state-sponsored trainings about Medicaid benefits. And this kind of information for care coordinators can help them to be better able to assist D-SNP enrollees in accessing and using the Medicaid services for which they qualify. And states that wish to review the D-SNP's model of care, D-SNP-only contracts can allow for simultaneous reviews of the model of care by both the state and NCQA, who reviews on behalf of CMS. Slide, please. D-SNP-only contracting also provides transparency on healthcare spending because the medical loss ratio in D-SNP-only contracts will be specific to the D-SNP enrollees included in those contracts. The medical loss ratio is the proportion of premium revenues spent on clinical services and quality improvement versus administrative costs and profits. And as I mentioned about quality measures and models of care, medical loss ratios are calculated at the contract level in Medicare Advantage plans. So when a Medicare Advantage contract contains multiple types of plans within a state or across multiple states, the medical loss ratio reflects the variety of plans included in the contract. But D-SNP-only contracting allows for more transparent oversight and understanding of the proportion of premium revenue that a state's D-SNP spend on clinical services and quality improvement for the dually eligible populations that they serve. Next slide. D-SNP enrollees and prospective enrollees can also benefit from D-SNP-only contracts in a few ways. Like Nita mentioned in the previous section, D-SNPs that operate with exclusively aligned enrollment within D-SNP-only contracts must use integrated versions of certain materials. And those are designed to make it easier for D-SNP enrollees to understand the full scope of Medicare and Medicaid benefits that are covered by the plan. And because models of care can be more customized to the enrollees in a specific state, they can be more directly applicable to the needs of the D-SNP enrollees within that D-SNP-only contract. And finally, enrollees and prospective enrollees will be able to use quality measures like Medicare Advantage star ratings to assess the performance of D-SNPs within the D-SNP-only contracts in their state. And that can help enrollees make more educated enrollment decisions about what plan is best for them. Next slide. There are also some potential benefits for D-SNPs. A joint, streamlined approach to CMS and state oversight can reduce burdens for D-SNPs that might result from duplication in current oversight practices or misalignment in state and CMS timelines, or conflicts in responses they receive from CMS and the state after separate CMS and state reviews of D-SNP materials. And the coordinated CMS and state model of care reviews could reduce the need for off-cycle reviews to incorporate state-specific requirements into models of care. And with that, I'm going to pass it off to my colleague Diane to explain the steps for implementing D-SNP-only contracts.
Thank you so much, Haley. Now that Haley has provided an overview of the benefits of D-SNP-only contracts, I will review the key steps that states and plans should consider when implementing D-SNP-only contracts. Next slide, please. The federal regulations that guide the implementation of D-SNP-only contracts, the 107E regulations, require minimum conditions that must be met for a state to request that CMS allow the state to require its D-SNPs to operate within D-SNP-only contracts. First, the state must either, 1, currently have D-SNPs operating with exclusively aligned enrollment, or 2, be planning to have states that will operate with exclusively aligned enrollment in the near future. Essentially, in the contract year that the D-SNP-only contracts will be implemented, the affected parent companies must each have at least one D-SNP operating with EAE. The second minimum requirement is that the state must agree to require the D-SNPs that operate with exclusively aligned enrollment and within D-SNP-only contracts to use integrated versions of at least the following required plan materials for communicating with D-SNP enrollees. These include summary of benefits, list of covered drugs or the formulary, and the combined provider and pharmacy directory. The state can require those D-SNPs to use additional integrated marketing materials and communications, but those 3 materials must be integrated by the plan in order for the state to implement D-SNP-only contracts. Next slide. On this slide, we provide a high-level timeline for all of the moving parts and steps required from states and plans if they were to implement D-SNP-only contracting for 2026. While the dates on here are specific for implementing contracts in 2026 as an example, similar timing and processes would apply to future plan years. We'll now go into some more of the specific steps for states over the next few slides. I want to note that in this timeline, we have highlighted the state-specific steps in blue, while the D-SNP specific steps are green. And this timeline for the D-SNPs map to the existing Medicare Advantage timing requirements. So for example, submitting notices of intent to apply by November and new applications for the D-SNP-only contracts and new models of care by February. I will also note that the reference that we've included at the bottom of this slide includes a link to the CMS guidance to states about D-SNP-only contracts, which has more details about implementation and CMS timeline expectations for establishing the D-SNP-only contracts. Next slide, please. For states moving forward with implementing D-SNP-only contracts in 2026, there are several key steps that the states will need to take in the next few months. First and foremost is engaging all interested parties, including Medicare Advantage organizations, dually eligible individuals or the organizations that serve them, provider groups, and others about the state's consideration and intent to implement D-SNP-only contracts. The engagement with these stakeholders will also provide states the opportunity to get their feedback on the state's planned approach and the timing of implementation. We also recommend that states reach out to CMS about their interest in requiring D-SNP-only contracts, as MNCO can answer many questions about the process and provide technical assistance as needed. To formally start the process of requesting D-SNP-only contracts, the state needs to officially notify CMS and the D-SNPs in the state of its intent to require D-SNP-only contracts. CMS recommends states notify the D-SNPs at the same time it notifies CMS. And to notify CMS, CMS requests that the state submit a letter to MMCO that notes that the state intends to establish D-SNP-only contracts and implement integrated materials by a specific plan year. CMS requests that states submit their letters of intent to require D-SNP-only contracts by August 15th of the year. That is 2 years prior to the implementation of those contracts. So for example, a state intending to establish D-SNP-only contracts and integrated materials for the 2026 plan year will need to notify CMS of the state's intent by August 15th of 2024. CMS includes a sample notification letter in the August 25th, 2022 guidance about D-SNP-only contracts. Next slide, please. After notifying CMS and D-SNPs of the intent to require D-SNP-only contracts, then there are a couple of other key steps for states to plan for in the fall. During this time, states should also convey any state-specific model of care requirements, if the state has any of these requirements, to their D-SNPs. D-SNPs will need to submit new models of care that are specific to the D-SNP-only contracts by February 2025. So the state should make sure that D-SNPs are aware of any state-specific requirements ahead of time, so the D-SNPs can incorporate them into their models of care. Also, after CMS has received the proper notification from the state should start working with CMS to develop the integrated versions of the required materials, which will need to be ready by late May or early June 2025. As mentioned before, these materials include the summary of benefits, list of covered drugs or formulary, and the combined provider and pharmacy directory. Next slide, please. As the timeline highlighted, for D-SNPs in states that are intending to establish D-SNP-only contracts, there are also several key steps for them to consider. First, as I noted in the previous slide, D-SNPs must submit notices of intent to apply and new CMS applications, both Medicare Advantage and D-SNP applications, for the new D-SNP-only contracts. Plans will need to submit these notices and applications within existing Medicare Advantage timelines. Also, D-SNPs will need to develop their integrated materials, including the summary of benefits, list of covered drugs, and the combined provider and pharmacy directory. These materials should be based on the templates that CMS works with the states to develop and provides to the D-SNPs in May or June of each year. D-SNPs will also need to submit a request to CMS to use crosswalk exceptions processes to move enrollees from the non-renewing D-SNP plan benefit package, or PBP, to the new D-SNP plan benefit package that is offered under the D-SNP-only contract. D-SNPs will also need to submit their executed state Medicaid agency contracts, or SMACs, to CMS in July 2025. Finally, D-SNPs will need to send annual notices of change, or ANOCs, to affected enrollees that explain their move to the new D-SNP plan benefit package in August, and they will need to send any new plan materials, for example, explanation of coverage and member ID cards, by September 30th of 2025. Thank you all for your time and attention. We will now end the recording, and I will turn it over to Molly to facilitate the question and answer portion of today's call.